So that finishes our CVA. Now move on to the diabetes and dyslipidemia. So the diabetes and dyslipidemia is a very big subject, and I will make you as short as possible in the next few minutes. See the lipid abnormalities in the type 2 diabetes, that is called diabetic dyslipidemia. So one term is diabetic dyslipidemia. In the diabetic dyslipidemia, you will have the three things. One is elevated triglycerides. The second one is reduced HDL, and the third one is LDL. Sometimes in LDL may be the normal, but the particle is very thick and the dense and more atherosclerotic. So that is diabetic dyslipidemia. So in diabetic dyslipidemia, you will have the triad: hypertriglyceridemia, low HDL, and LDL may be higher or with the normal with the dense and thick LDL, that is atherosclerotic LDL. So here one is the increased triglycerides, the second one is the decreased HDL, and the third one is the LDL. See third one, quantitatively normal or increased LDL, maybe the normal also. No, it's very difficult clinically. No tests. Clinically it's not possible. So the qualitatively heterogenic small dense LDL and oxidatively modified LDL. Okay. The similar derangements in the lipid profile are seen in the Asian Indians, even in the absence of the diabetes. See, the goal of the LDL right now is very, very low. So earlier 130 LDL goal, later it's 100. Now it is less than the 70, even the 50 or even the 35. So it's very, very difficult to reach that goal. So now the present concept of all the diabetes, my goal is less than 70 in most of the diabetic individuals. In very high risk individuals, even the less than the 50 is also our goal. But it's very, very difficult to achieve that. So you need to use the high dose of the statins. You have to add the ezetimibe. Sometimes you have to add the bamburic acid. Sometimes you have to use the PCSK9 inhibitors. Okay. Now they are also available in the market. So these are all the important drugs. Okay. Fenofibrate, when the fellow is also having associated triglycerides. When the LDL is high, triglycerides also very high, then you can add the combination of the statins plus fenofibrates. In the presence of the normal triglycerides, no need of using fibrates. So the only statins. Statins alone, your question number 1. Or statins plus ezetimibe, number 2. Or statins plus bamburic acid, number 3. Or statins plus fibrates, number 4. Or statins plus monoclonal antibodies, like your PCSK9 inhibitors. So this is how right now we are treating the dyslipidemias. So not only the statins and the fibrates, so some more other drugs are also available right now to treat the dyslipidemias. See, this is the pathogenesis of the diabetic dyslipidemia. Triglycerides in the liver. So the VLDL, 1/5 of the triglycerides is the VLDL. So they are the hypertriglyceridemia, low HDL levels, increased small dense LDL, heterogenic lipid profile, or diabetic dyslipidemias. See, the TG replaced the VLDL, the transfer of the TG and the CD. So HDL formation on one hand and LDL formation on the other hand. See the small and the dense LDL, they are more atherosclerotic, and HDL, more the HDL, more the protection. But unfortunately, so in our Indian population, we have the degradation of the HDLs and so low HDL levels. So on one hand we have the low HDL levels, on the other hand we have the small and the dense LDL, even though the LDL particles are the normal. See here in the second chart. So we have the small. So this is the small and the dense LDLs, more atherosclerotic. So the importance of the non-HDLC cholesterol. What is non-HDL cholesterol? Your cholesterol minus HDL. So in the lipid profile, you will get the 5 values. What are they? Cholesterol, triglycerides, HDL, LDL, VLDL. So cholesterol, triglycerides, HDL, LDL, VLDL. So how to get the non-HDLC cholesterol? So non-HDLC cholesterol means cholesterol minus HDL. Cholesterol minus HDL is non-HDLC cholesterol. That you have to calculate. Suppose cholesterol is 200. HDL is 40. So what is your non-HDLC cholesterol? 160. Suppose cholesterol is 300. HDL is 30. So what is your non-HDLC cholesterol? 270. So that is your non-HDLC. This is much more important than these 5 values. So from tomorrow onwards, whenever you see the lipid profile values, You also get the non-HDC cholesterol by yourself. So write it on the paper. What are all the paper you are seeing in the lipid profile? Write it as the non-HDC cholesterol. Non-HDLC cholesterol, cholesterol minus HDL. Whenever you see my reports, no, so I will get the non-HDLC cholesterol. Because my wife is a pathologist, she get the non-HDLC cholesterol. Immediately after getting the cholesterol minus HDL, she write as a sixth parameter as a non-HDLC cholesterol. So non-HDLC cholesterol is much more important than the cholesterol or the HDL or the LDL, etc. Because it is more say equivalent to your apolipoprotein B. See which molecule, which lipoprotein is more atherosclerotic in the body is apolipoprotein B. So that apolipoprotein B is very costly. To test the apolipoprotein B, you have to send the blood to the higher centers. The cost is about 3,000 to 5,000 rupees. So by indirectly you are calculating the non-HDC cholesterol, it is as equivalent as the apolipoprotein B. Yeah. So yes, you can consider that as a marker for your apolipoprotein B. So you can get the non-HDC cholesterol. So lipid profile values are in front of you, but you are not having the apolipoprotein B. It is not being done at Kakinada or Mummudivaram or in Amalapur or in Rajahmundry. So you have to send the blood to the higher centers. So instead of sending the blood to the higher center, you can get the apolipoprotein B indirectly. So by calculating the non-HDC cholesterol. Am I clear? So non-HDC cholesterol, you should keep the goal of the non-HDC cholesterol is 30 plus your LDL goal. Suppose your LDL goal is 100. So what is your non-HDC cholesterol? 100 plus 30, 130. Suppose your LDL goal is 70. What is your goal of non-HDLC cholesterol? 100. Suppose your goal of non-HDLC LDL cholesterol is 50. So your non-HDLC cholesterol goal is 80. Am I clear? So that's how you have to keep the things. So your goal of cholesterol is less than 200. Your goal of triglycerides is less than 150. Your goal of HDL is males more than the 40, females more than the 50. Then your goal of the LDL is depends on the person. So in all the very complicated patient, lot of the comorbidities, you can keep the LDL at 50. Suppose only diabetic, a young fellow, non-smoker, etc., your goal is 70. Suppose a non-diabetic, a young fellow, even maybe your goal is 100. So depending on the LDL goal, your non-HDC cholesterol goal will vary. Suppose 100 means non-HDC cholesterol will be the 130. Your goal of LDL 70 means non-HDC cholesterol goal is 100. So in the like that, you have to see it. So you need not remember the VLDL. VLDL is obsolete because VLDL is nothing but 1/5 of the triglycerides. 1/5 of the triglycerides. Cholesterol, dyslipidemia, yes. The familial hypercholesteremia is also a risk factor for the atherosclerosis. So, but in familial hypercholesteremia, the people's cholesterol will be very, very high. So total cholesterol will be 300, 400, and the triglycerides will be no, the same thing, same. We have to treat them very aggressively. Even with the PCSK9 inhibitors also, we have to use them. So in the familial hypercholesteremia, I have seen few patients with total cholesterol 350, 450, 500, and almost the cholesterol is almost like cream. Okay, so the triglycerides will be 2,500, 3,000. It is very difficult to get the LDL also. In the presence of severe hypertriglyceridemia, it is very difficult to reach to calculate your LDL goals, LDL levels. So by seeing the serum, we can say this fellow is having the normal cholesterol or abnormal cholesterol. Familial also you have to treat it. Suppose if the high cholesterol is there, you have to use the cholesterol lowering agents like statins. Suppose the high triglycerides, you have to use the fenofibrate. Okay, in that way you have to use them. Suppose the both are there, you have to use the combination of the statin plus fenofibrate. So how often to test? The first answer is you need not test to start the statins in a diabetic individual. That is the first take home point. All the diabetics, they need a statin unless otherwise contraindicated. So all the high risk diabetic individuals, all the diabetes plus hypertension, diabetes plus obesity, diabetes plus smoking, diabetes is a strong family history of your vascular events. Even without the lipid profile also, you can have to start the statins. Then what is the need of the lipid profile? So lipid profile values will tell you whether you are right in initiating the statin therapy. The dose of the statins will be dictated by the lipid profile values. Suppose you are started with 10 milligrams of the rosuvastatin. His LDL is 70. Do you continue the 10 mg or continue or increase to 20 mg? Continue 10 mg. No problem. Okay, Vayarki? Suppose you are started with the 10 mg of the rosuvastatin and you are getting the LDL cholesterol. The LDL cholesterol is 130. Your goal is 70. So you are starting with the 10 milligrams. So is it possible to reach the 70 with the 10 milligrams? Not possible. So you have to increase the dose of 10 milligrams to 20 milligrams. So to know the exact dose of the statins, you need a lipid profile. To start the dose of the statins, you don't require the lipid profile. Am I clear? Okay. So that is it. So this is the very important slide. Lipid Association of India guidelines. Assessment of the risk category. See the major atherosclerotic cardiovascular disease risk factors. These first one, 5. Age more than 45 years in the males, more than the 55 years in the females. So there is a major risk factor for the atherosclerotic cardiovascular disease. So the age itself is a big risk factor. When the males more than the 45 and females more than the 55. Number 2, family history of a premature atherosclerotic cardiovascular disease. So the father died of the myocardial infarction at the age of 50 years. Her mother got the myocardial infarction at the age of say 55 years. So that itself is a big risk factor for the atherosclerotic cardiovascular disease. So one is the age, that is a non-modifiable, family history, non-modifiable. And the third one, current cigarette smoking or the tobacco use is a big risk factor. And high blood pressure and low HDL-C cholesterol is also a risk factor. So out of them, without your knowledge, how many factors are there with us? Atherosclerotic cardiovascular disease. One is the age, the second one is the family history, and the third one is the low HDL-C cholesterol. Unfortunately, most of the Indians are having low HDL Indians. So the 3 out of the 5, the 3 without our knowledge, we are all having the factors. Suppose if you are a smoker, so definitely the 4th one is there. And if you are an hypertensive, again the 5th one is also there. Now the other high risk factors, these are the major risk factors. They are the other risk factors, diabetes, CKD, familial hypercholesterolemia, extremes of a single risk factor, calcium score, coronary calcium score more than the 300, non-stenotic carotid plaque, lipoprotein A. So these are other risk factors. Then the moderate risk, non-conventional risk factors, calcium score 100 to 300, increased carotid intima media thickness, lipoproteins, impaired fasting glucose, increased waist circumference, that is your obesity, then the high sensitive CRP. So these are the other risk factors. So, okay, those are the risk factors. Most of our diabetes will be having those risk factors. Now please concentrate on the lower one, the risk group, low risk, moderate risk, high risk, very high risk, and extreme risk. So this is the very important for all of us practically. Low risk, 0 to 1 major atherosclerotic cardiovascular risk factors, and lifetime CVD risk less than 30%. So none of the people will have the low risk. 0 to 1 at a major. Suppose your age is more than 41, 15, itself you are not a low risk individual. A strong family history, itself you are not a low risk individual. So only maybe 0.5 to 1% of the population will be in the low risk individuals. So you forget that one. Then the moderate risk. See the moderate risk. 2 major atherosclerotic cardiovascular risk factors. Low risk group with more than 1 moderate. Lifetime CVD risk more than the 30%. Again, the moderate is a lot of the people will come under the moderate risk. Because 2 major atherosclerotic cardiovascular disease. This is the 5 major. One is your age, then the strong family history, then smoking, then the low HDL cholesterol, and then your blood pressure. So moderate risk factor. Then coming to the high risk. High risk more than the 3 risk factors. And the very high risk, pre-existing atherosclerotic cardiovascular disease, diabetes. So see the presence of the diabetes. So the presence of the diabetes itself is a very high risk individual. So all our diabetic individuals with dyslipidemia or without dyslipidemia, they are in the very high risk individuals. So you please concentrate that group. So the diabetes, we are dealing diabetes. That means we are dealing with very high risk individuals. Now the extreme risk individuals. See the extreme risk individuals. They are divided into two groups, A and the B. A, coronary artery disease with more than the one feature of high risk individual. Already had a coronary artery disease, had angina, or had PTCA, or had CABG, etc. So he will be extreme risk individuals in a diabetic. And then the B category, coronary artery disease and very high risk group individuals and polyvascular disease. So in a single word, in this slide, you see that high risk individuals are the 5 groups, and the diabetes comes under the very high risk individuals, and even the extreme risk also, provided if you had in the past history of the coronary artery disease. So am I clear? Now, Lipid Association of the India guidelines, LDL goals, your goal, LDL goals. One, diabetes without any atherosclerotic cardiovascular disease. Then the diabetes with atherosclerotic cardiovascular disease. Now, diabetes without atherosclerotic cardiovascular disease, no target organ damage. They are at the high risk individuals. LDL goal, what is your LDL goal? Less than 70. So in all the diabetic individuals, the minimum HDL goal is 70. Because he didn't have any atherosclerotic cardiovascular disease, diabetes. And also no target organ damage, no LVH. ECG is normal, X-ray is normal, creatinine is normal, everything is normal, no target organ damage. Even the LDL is less than the 70, simply because he is a diabetic. Suppose diabetes without atherosclerotic cardiovascular disease, but he has a target organ damage, like your ECG shows LVH, that itself is a target organ damage. Your cholesterol, your creatinine 1.2 or 1.4, so that suggests of CKD, early CKD. So that means target organ damage. So what is your LDL goal? Less than 50. Remember that the fellow without atherosclerotic cardiovascular disease. So the diabetes without atherosclerotic cardiovascular disease, no target organ damage, the minimum is 70, less than the 70. So what is our take home point? All the diabetics less than the 70. Suppose if the diabetic with the target organ damage less than 50. Now coming to the other group. So other group means cardiologist group. Diabetes with atherosclerotic cardiovascular disease. Already had atherosclerotic cardiovascular disease. So now see the two groups, category A and category B. What is the goals? Less than 50, less than 30 or less than 30. So all the diabetes in the cardiology practice, our goal should be less than 50 or 30. So somewhere between 30 to 50. So other than the cardiologist, from all of us, the goal is somewhere between 50 to 70. So that is the most important. It is very easy to say that your goal is 50, your goal is 70, your goal is 30. Very, very difficult to reach. Even the 10 milligrams, a lot of the people will have myalgias, rosuvastatin or atorvastatin or rhabdomyolysis, or you see your CPK NAC will be elevated. So it is very coenzyme Q, sir. Coenzyme Q. So that will be useful in the management of myalgias, rhabdomyolysis caused by the statins. Coenzyme Q. Coenzyme Q. Coenzyme Q is available in the market. So approach to the management, therapeutic lifestyle changes, improvement of the glycemic control, and the drugs. See the drugs were last one in the dyslipidemias. So what is the first one? Lifestyle change. What do you mean by the lifestyle changes? Food, exercise. So the food changes like your saturated fats, trans fats. Okay, dum biryani. Okay, evening masala vada. Okay, gare, bhaji, jalebi. So these are all rich with fats, especially trans fats. So that is the therapeutic life changes and your exercises. So this is very important. What is the second one in a diabetic individuals? Improvement of the glycemic. So the diabetes, uncontrolled diabetes, you will have hypertriglyceridemia. Okay. So once you control the diabetes very effectively, the triglycerides also will come down. So that is the reason I say that isolated hypertriglyceridemia in the presence of uncontrolled diabetes, don't treat with the fibrates. Again, I am repeating. Isolated hypertriglyceridemia in the presence of uncontrolled diabetes. Don't use any fibrates. Control the diabetes very effectively, the triglycerides also will come down. So then the second question. Isolated hypertriglyceridemia In the presence of controlled diabetes, treat with good answer. Treat with the 5%. So in all the diabetic individuals, before you start the any lipid therapy, you see whether the diabetes is under control or not. If the diabetes is not under control, so please consider the diabetes has to be controlled very effectively. Then the drugs will come. So then the drugs will come. So now the therapeutic measures, diabetes control, and then the drugs. So what are the therapeutic lifestyle changes? Weight loss. Weight loss reduces the triglycerides and increases the HDL-C cholesterol. So the mainly two ways will increase the HDL-C cholesterol. One is exercise and number two is alcohol. Moderation of the alcohol. So moderation of the alcohol will increase the LDL cholesterol, HDL-C cholesterol, and then your exercise will increase the HDL-C cholesterol. So we increase the alcoholism. So the only thing is exercise will increase your HDL. Suppose if the person is a chronic alcoholic, so it's very difficult to stop the alcohol, then the moderation of the alcohol we advise, that will help him to improve the HDL-C cholesterol. But higher amounts of the alcoholism also will not improve the HDL-C cholesterol. So this is the very important. Diet, saturated fat restricted to the less than the 7% saturated fat. So the total fat will be 25%. So 7% will be saturated, 7% will be monounsaturated, 7% will be polyunsaturated. So it should be less than the 7% is the saturated fat. And trans fats, 0. Cholesterol, less than 200 milligrams. Increase the dietary fiber. So dietary fiber is always helpful. Increase the physical activity. So patients on the total lifestyle changes, therapeutic lifestyle changes, should be reviewed every 3 to 6 months. And considered for the pharmacotherapy if needed. Now the case study. Female 28 years. Both her parents have type 2 diabetes. Her fasting blood glucose is 98. On OGTT, her 2-hour glucose is 182 milligrams. Her total cholesterol is 284. LDL is 164. HDL is 32. Triglycerides is 244. She is not on any treatment. She wants to try the lifestyle before starting the drugs. Good. Her height is 162 and weight is 84 kgs. So what is the working diagnosis here? So working diagnosis is less than 30 years of age group. Okay. Both the parents, strong family history of the diabetes. Fasting blood sugar is 98. 2-hour glucose is 182. So is it normal? What is the condition you consider it as? Pre-diabetes. Pre-diabetes, which type of the pre-diabetes? Fasting is the normal. So fasting between 100 to 125 unte impaired fasting glucose anta. So here IGT. So impaired glucose tolerance. So that is a pre-diabetic. So strong family history. Now she is a pre-diabetic at the age of 28 years. Now the total cholesterol 284. So hypercholesterolemia. LDL 164 is very high. HDL 32 is very low. She is a female. Should be more than 50. So 32 is very low. Triglycerides 244. She is not on any treatment. She wants to try the lifestyle changes before starting the drugs. Now coming to the height and the weight, BMI. Height is 162. So the normal weight is 162 minus 100. So the normal weight is 62. But the actual weight is 84. So she is obese. So what is the working diagnosis here? Pre-diabetic, dyslipidemia, obesity. So diabetes plus dyslipidemia. See at the age of 28 years. So ఇదే మనం నెగ్లెక్ట్ చేసామనుకో, by the time she is 35 years, she will be pakka type 2 diabetic and also hypertensive and also dyslipidemia, and she may present with a cardiologist with a myocardial infarction also. So because impaired glucose tolerance itself is an independent risk factor for the cardiovascular diseases. So she had impaired glucose tolerance, pre-diabetes. Okay. So what condition does she have? Diabetes plus dyslipidemia. What diet advice will you recommend to her? Here you can spend lot of time. No drugs, only diet. So reduce the carbohydrates because she is already pre-diabetic. Improve the proteins. Reduce the cholesterols. No trans fats. Saturated fats less than the 7%. more of the unsaturated and the polyunsaturated, monounsaturated fatty acids, and more fiber, less salt. Okay, less saturated, sorry, processed foods very less. Okay, maybe millets more, maybe quinoa. Now the quinoa is good, doing good, or brown rice. Okay, stop rice, white rice. So these are very, very important. More fruits. Then the physical activity. How much? Not 30 minutes a day. Maybe 60 minutes a day. Or maybe 1.5 hours a day. So 3 slots. Each slot about 30 minutes. Or morning and the evening. Each slot about the 45 minutes. A lot of the things has to be done to have. With your good exercise, with your good dietary approach, she will come to the normal stage. So the weight reduction is possible. IGT will become the normal is possible. And then other thing is lipid profile is also a possible. Normal lipids also possible. So you are giving more good health to her without any interventions. Only with the therapeutic lifestyle changes. So the therapeutic lifestyle changes will help her a lot in this particular patient. Still, after 2 months or after 3 months of the therapeutic lifestyle changes, still the body weight is the same or still the cholesterol is the same, then definitely you have to use some drugs. So which drugs you use? Suppose if therapeutic lifestyle changes fails here. For diabetes, what you use? Good, metformin you can use. You can use even the SGLT2 inhibitor you can use. Or you can use the GLP-1 receptor agonist like oral semaglutide you can use. So out of these 3 drugs you can use. If the patient is very poor, you can use the metformin. If the patient can afford, you can use the GLP-1 receptor agonists like oral semaglutide. If the midway, even you can use the dapagliflozin also. Okay? But when you are using the dapagliflozin, take care that takes a lot of the fluids. Otherwise, the chances of having the urinary tract infections and the monial infections are much more when compared to the non-SGLT2 inhibitor individuals. That is one way of treating your diabetes part. And then whatever the lipids, which drugs you prescribe here? So use the statins. Because if you see the cholesterol elevation is here, LDL elevation is here, triglyceride elevation is here. Okay? And HDL reduction is also there. All the drugs will act on all the 3 drugs. Suppose statins will act on the 3. 1, they reduce the LDL, they reduce the triglyceride, they increases the HDL. Suppose if you are using the fibrates, they reduce the triglycerides, they reduce the LDL, they improve the HDL. Am I clear? So both the statins as well as the fibrates, they reduce the LDL, they reduce the triglycerides, and they elevate the HDL. Now the second point for you is statins, they reduce the LDL much lower, they reduce the cholesterol much lower when compared to the triglycerides. Okay, suppose if you are using the fibrates, they lower the triglycerides much deeper when compared to the statins, when compared to the LDL cholesterol and the cholesterols. So third point, when you are using the statins, 60% reduction will be there with the LDL and the cholesterol, 20% reduction will be seen with the triglycerides, and about 5 to 10% hike will be seen with the HDL. So when you are using the fibrates, there will be 80% reduction with the triglycerides, about the 15% reduction with the LDL, and maybe 5 to 10% elevation with the HDL. And then the fourth point, HDL hike is more with the fibrates when compared to the statins. So am I clear? So statins will reduce the more of the LDL, more of the cholesterol, less of the triglycerides, and then less of the, let's say, hike of the HDL. And the fibrates, they reduce triglycerides very effectively. They also reduce the cholesterol and the LDL to some extent, and they elevate the HDL more than the statins. Okay. Improvement in the glycemic control. See, can modestly reduce the triglycerides. I already told you. So hypertriglyceridemia. So control the diabetes very effectively. Usually minimal effect on the HDL or the LDL. Metformin, sulfurias, and acarbose, they reduce the triglycerides. Pioglitazone reduces the TG levels, but increases the both the HDL and the LDL. SGLT inhibitors have been shown to increase both the LDL and the HDL. Okay, so this is about your diabetes. So if you control the diabetes effectively, triglycerides will come down. So they have the minimal effects on the HDL or the LDL. Metformin, sulfurous acarbose, they reduce the triglycerides. Pioglitazone, they reduce the triglyceride levels. SGL inhibitors shown to increase the both the LDL and the HDL levels. Drug therapy indications simultaneously with the total therapeutic lifestyle changes. So even though if you are using the statins or the fibrates, so don't underestimate the value of the lifestyle changes. That is very, very important. If the therapeutic lifestyle changes fails to achieve the targets of the 3 months, then the options, statins, how they act, HMG coenzyme A reductase inhibitors. They are the drugs of the choice for the dyslipidemia and the diabetes. Other agents such as the fibrates, niacin, ezetimibe, PCSK9 inhibitors, and bempedoic acid may be useful in the selected situations. I have told you something about the fibrates. I told you the ezetimibe, PCSK9 inhibitors, bempedoic acid, but I didn't say anything about the niacin. In fact, niacin is the first lipid lowering agents available in the market way back in the 60s and the 70s also. But they are not commercially popular because of the lot of the gastrointestinal side effects. So the niacin therapy will cause you abdominal pain, abdominal cramps, nausea, vomiting, and they are not palatable. So the people are getting a lot of the side effects, especially the gastrointestinal side effects with the niacin therapy. So that is the reason the niacin therapies was not popular, even though they are the first anti-lipid lowering agents available in the market. But statins and ezetimibe and PCSK9 inhibitors, bempedoic acids, they are now the very popular. How the statins act? I told you now, HMG coenzyme A reductase inhibitors. See, the acetyl coenzyme A will become the HMG coenzyme A. So this will become the mevalonate and then the cholesterol. So by using the statins, we are preventing the synthesis of the cholesterol from the HMG coenzyme A. So that's how these act. So there's the very, very important drugs to be used in all the diabetic individuals to reduce the synthesis of the cholesterol. They significantly reduce the LDL, more modest effects on the HDL and triglycerides. I told you no. So the statins will act on the other three also. Simva, Etorova, Rosva, Pitavastatin. In America, they use more of the simvastatin. Even today, we see a lot of the prescriptions use the simvastatin. But in India, we don't use the simvastatin. We use either atorvastatin or the rosuvastatin. And pitavastatin is useful in HIV individuals. So in India, we use more of atorva and rosuvastatin. And drug to drug, rosuvastatin is superior to the atorvastatin. But atorvastatin is more popular in India for the last 20 years. So those people who are on the atorvastatin for the last 15 years or 20 years, if they are maintaining the normal lipid profile levels, don't change to rosuvastatin. Suppose if you want to give the first prescriptions, rosuvastatin is superior to the atorvastatin. Am I clear? Suppose my uncle or my mother, she has been on atorvastatin for the last 20 years or 15 years. You know, the lipid profiles are the normal. So as I am saying that rosuvastatin is superior to the atorvastatin, you need not change to the rosuvastatin. Here continue the atorvastatin. Suppose if you want to give the first prescription to your brother, with the LDL is say 130 or the total cholesterol is 230, then you can prefer the rosuvastatin over the atorvastatin. So the new prescriptions more of the rosuvastatin, and old prescriptions if they are maintaining the normal lipid levels, you can continue the atorvastatin. So even after the 10 years or 15 years of the atorvastatin therapy, still the levels are very, very high. Then you can stop using the atorvastatin, then start using the rosuvastatin. So statins, they have the pleiotropic effects. So the endothelial function, they improve the endothelial function. That is very, very important for us. So endothelial dysfunction, yeah. Antithrombotic, anti-inflammatory, immunomodulatory, antioxidant, vascular cytoprotection, angiogenesis, and plaque stability. So these are all the advantages of the statins. So endothelial function will improve, antithrombotic, anti-inflammatory, immunomodulatory, antioxidants, vascular cytoprotection, angiogenesis and plaque stability will be seen with the statin. That is the reason for all the cardiologists and the diabetologists, statins are very, very important drugs, very useful drugs. So now the recommendations. The primary prevention. For patients with diabetes aged 40 to 75 years without atherosclerotic cardiovascular disease, use the moderate intensity statin therapy. What you mean by the moderate intensity statin therapy? Now the statin therapy is divided into three groups. One is low intensity statin therapy, moderate intensity statin therapy, and high intensity statin therapy. Okay. In India, there is no role of low intensity statin therapy. We have only two things. What are they? Moderate intensity statin therapy or high intensity statin therapy. So 10 mg of your rosuvastatin or 20 milligrams of the atorvastatin is moderate intensity statins. Suppose 40 milligrams of the atorvastatin or 20 milligrams of the rosuvastatin or 80 milligrams of the atorvastatin or 40 milligrams of the rosuvastatin. So that is a high intensity statin therapy. So statin therapy is divided into three groups: low intensity, medium intensity, and high intensity. In India, there is no low intensity statin therapy. We have only two things: moderate intensity or high intensity. So use the atorvastatin up to the 20 milligrams is the moderate, or rosuvastatin up to 10 is the moderate, or rosuvastatin 20 or 40 and atorvastatin 40 and 80 is the high intensity. Suppose post PTCA or post CABG, so use high intensity statins. So that is the reason cardiologist prescription immediately after the PTCA, atorvastatin 40 mg, atorva 40 mg, or atorva 80 mg, or rosuvastatin 20 mg, rosat 20 mg, or rosuvastatin 40 mg. So that is high intensity statin. After 6 months or after 1 year, when the LDL is very low, say 50 mg or 30, then you can reduce the dose to the 10 milligrams of the rosuvastatin or 20 milligrams of the atorvastatin. But initial days, when you want to use the high intensity statins, use minimum 20 milligrams of the rosuvastatin and 40 milligrams of the atorvastatin. So secondary prevention. Yes. So I told you aspirin for a primary prevention, double-edged weapon. Secondary prevention, aspirin, 100% yes. Whereas for the statins, primary prevention, 100% yes. Secondary prevention, 100% yes. Am I clear? So statins should be used for both the primary prevention as well as the secondary prevention. So for patients of all ages with diabetes and atherosclerotic cardiovascular disease, high intensity statin therapy should be added to the lifestyle therapy for a secondary prevention. For patients with diabetes, atherosclerotic cardiovascular disease, considered very high risk using the specific criteria. If LDL cholesterol is more than the 70 and maximally tolerated statin dose, consider adding the additional LDL lowering therapy such as ezetimibe or PCSK9 inhibitor. This is the take home point. Suppose if you are using the statin, say rosuvastatin or the atorvastatin, higher dosages, then after the 3 months, your goal of the LDL is less than the 70. But still the LDL goal is 80 or LDL is 90 or 100. So how to control? Already you are using the higher therapeutic doses of the statins. Then you have the two options. You can add the ezetimibe or you can add the PCSK9 inhibitor. Now you have the third option is you can add the bempedoic acid also. So these three are very important. Okay. So to reach your 30 at the 50, statins alone not possible. So statin plus ezetimibe or statin plus bempedoic acid or statin plus PCSK9 inhibitors is needed. So now the general points. For patients who do not tolerate the intended intensity, the maximal total statin dose should be used. If adults with aged more than 75 years already on the statin therapy, it is reasonable to continue the statin therapy. In adults diabetes more than the 75 years, it may be reasonable to initiate the statin therapy after discussion of the potential benefits and the risks. See, the statins, the benefits are much more when compared to the risks. Risks are only one thing, myalgias, rhabdomyolysis. So this is a high intensity. I told you that lowers the LDL cholesterol by 50%. That is the meaning of the high intensity statins. Lowers the LDL cholesterol by 50%. Atorvastatin 40 to 80 milligrams. Rosuvastatin 20 to 40 milligrams. Moderate intensity, lower the LDL cholesterol by 30 to 50%. Okay. Suppose, for example, you are a diabetic patient with LDL 100. Do you use high intensity or moderate intensity? Good. So LDL is 100. So even 30% reduction. So your goal is 70. So then you can use the moderate intensity statins. Suppose the LDL is 130. your goal is 70. High intensity statin, because LDL cholesterol lowers by 50%. So that depends on the patient. So depends on your index patient. You can choose whether it is high intensity statins or the moderate intensity statins. The adverse effects myopathy, ranging from the non-specific myalgias to the frank rhabdomyolysis, GI side effects like nausea and flatulence, CNS side effects like insomnia, nightmares. New onset diabetes and progression of the diabetes have been reported. That is also important. Statins, new onset diabetes will be there. But if you see the risk versus the gains are much more when compared to the risk of getting the new onset diabetes. Okay. So that is the reason we never think of the new onset diabetes as a risk factor or as a negative point to use the statins. Yes, the important point thing is contraindicated in the pregnancy. So statins are contraindicated, diuretics are contraindicated, ACE inhibitors or ARBs are contraindicated in pregnancy. So in all the diabetics, now we are getting the type 2 diabetes at the age of 15 years or 20 years. Yesterday I have seen one patient, not yesterday, maybe Thursday, female girl aged about 14 years with high blood sugars, with acanthosis nigricans, skin tags, childhood obesity, and both the parents are the diabetics. So both the parents are under my care and they brought their child. So what is the type of the diagnosis she is suffering? It is not type 1 diabetes. It is type 2 diabetes. What are the factors to say it is a type 2 diabetes in here? One is strong family history. The second thing is obesity. The third thing is acanthosis nigricans and the skin tags. So acanthosis nigricans and skin tags are the features of insulin resistance. Suppose you are diagnosed type 1 diabetes. What you mean by the type 1 diabetes? Insulin deficiency rather than the insulin resistance. So same fellow, same girl, suppose no family history, very lean, loss of body weight, diabetes. So undoubtedly it is a case of type 1 diabetes. Even though you send the blood for the GAD65 antibodies, that will be the positive. If you send the blood for the C-peptide levels, that will be lower. So by experience, you can say whether the fellow is the type 1 diabetes or type 2 diabetes. This girl is the type 2 diabetes. So you need not send the blood for the C-peptide or the GAD65 antibodies. With the three important things, a strong family history, obesity, and then the skin tags and the acanthosis nigricans, straight away started her on metformin. Okay, so see, this is very, very important. So the same thing, the new onset diabetes contract in the pregnancy. See, other thing is measure the liver enzymes in the statins therapy before starting the treatment. Subsequent measurements only on the clinical indication, levels more than the 3 times upper level of the normal warrant the discontinuation of the statins. So on the statin therapy, get the SGPT, SGOT done. Suppose if the SGPT or normal values is up to the 40, suppose the SGPT is 120. So better to reduce the dose of the statins or stop the statins. Suppose if the SGPT is 60 or the 70, do you discontinue the statin? No, you have to continue the statin because the 60-70 may be because of the fatty liver. Even in the fatty liver also the statin, the SGPT, SGOT will rise. So in such situations you have to use the statins. Other drugs, HDMI. HDMI is a good drug. It is not a drug by itself because it reduces the cholesterol very minimally. But in the presence of the statins, they act very better because HDMI is nothing but absorption. Cholesterol absorption inhibitor, like your oglibose. Oglibose is your carbohydrate absorption inhibitor. In the same way, HDMI is your cholesterol absorption inhibitor. So it blocks the Niemann-Pick C1 like protein, a critical mediator of cholesterol absorption on the GA epithelial cells as well as in the hepatocytes. Thereby it interferes with dietary cholesterol absorption. Less potent than the statins. It is not that potent with the statins. But the combination of the statin and the HDMI has shown to lower the LDL to a greater extent. This is very important. A combination. Okay. And reduces the risk of the adverse CV events compared to the statins alone. Generally well tolerated except for the occasional headache and the malabsorption. See in the old cinemas, Rao Gopal Rao and Allu Ramalingiya. See the Rao Gopal Rao is a statin and Allu Ramalingiya is a HDMI. Okay. Both are very worst fellows in the rural politics. Okay. So So for a individually they are good people, but in the movies I am saying that both died of diabetes. Ragopal was a great actor. He died of uncontrolled diabetes. Diabetic autonomic neuropathy, diabetic cardiomyopathy, heart failure, nephropathy, renal failure. He died of the diabetic complications. So even at the age of less than 60 years, maybe 59, 58 years. 58 years. Other LDL lowering drugs like PCSK9 inhibitors, erokomab and evolocumab. They are the drugs available around. They are very costly. They are costing about 1 lakh, 1.5 lakh rupees. So, so they use it in the ICUs, in the cath labs. When the cardiologists say that, when see that the vessel is very much calcified, lot of the thrombus is there in the vessel. So then they advise this evolocumab and evolocumab. So they are the PCSK9 inhibitors. They can decrease the LDL levels by 36 to 59%. So the bambudoic acid, now it is coming up. Last 6 months to 1 year we are having this molecule. This is a novel hypolipidemic agent that acts by inhibiting the ATP citrate lyase enzyme in the hepatic cholesterol synthesis pathway. So the mechanism of the action: increase the upregulation of the LDL receptor, increase the LDL-C clearance, and reduces the plasma LDL cholesterol. So this acts in the hepatocyte. Your statins, they act through the HMG coenzyme A reductase inhibitors. The cholesterol synthesis absorption inhibitor will be there. Cholesterol synthesis will be inhibited by the statins. Cholesterol absorption will be inhibited by the ezetimibe. But here it is increases the LDL cholesterol. See, clearance. So LDL-C cholesterol clearance will be increased so that the plasma LDL level will be reduced with the bambudoic acid. So you can combine the statins and the bambudoic acid plus the ezetimibe, because the different actions. We should not combine the atorvastatin and the rosuvastatin because of the similar actions. So it is an inactive prodrug that is converted to the active agent only in the liver and not in the muscle. Hence myopathies are rare. Here the myopathy is very rare. So those people who are not tolerating the statins, so we use this drug, bambudoic acid. Okay, found to be safe and effective in patients with residual CV risk who are on maximally tolerated dose of the statins. Earlier, no, when the statin are not tolerable, you don't have any drug. No bambudoic acid, no PCSK9 inhibitors. Now you have the option for those people who are not tolerating the statins. So either the bambudoic acid or PCSK9 inhibitors. Here the side effects: hyperuricemia and the gout and tendon rupture. Dose is 180 milligrams OD. Now it is available. So treatment of the other lipoprotein fractions. For patients the fasting triglyceride levels more than the 500, evaluate for the secondary causes of hypertriglyceridemia and consider the medical therapy to reduce the risk of the pancreatitis, especially the alcoholics. The triglyceride levels will be very, very high. So alcoholic pancreatitis. Okay. In adults with the moderate hypertriglyceridemia, fasting or the non-fasting triglycerides, clinicians should address and treat the lifestyle factors like obesity and metabolic syndrome, secondary factors: diabetes, CKD, nephrotic syndrome, hypothyroidism. See, this is the triglycerides treatment. Again, the Lipid Association of India. See the TG between 150 to 200. Do you treat? Usually not. With therapeutic lifestyle measures, okay. Okay. Lifestyle interventions only. When the TG 200 to 500, so measure the LDL-C cholesterol, calculate the non-HDL-C cholesterol, assess the atherosclerotic cardiovascular risk, lifestyle measures, add the statin plus the ezetimibe. Okay. Suppose if the TG is more than the 500, the third one and the fourth one, or more than the 1000, finally the yellow one, consider the statins plus the ezetimibe to achieve the LDL-C cholesterol. If high LDL cholesterol there, the TG levels are very high, consult the lipid specialist. A genetic testing and the newer drugs may be required, like your fenofibrate, PCSK9 inhibitors, etc. So these are the fibrates. Activate the PPR alpha in the liver. So the same PPR gamma, what drugs will act on the PPR gamma? Thiazolidinediones, pioglitazone. That is for the diabetic management. PPR gamma. PPR alpha for the triglycerides here. Now in India, you have the one molecule which acts both on the PPR alpha and the gamma. What is the drug? Saroglitazar. Saroglitazar. that saroglitazar will act both on the PPR alpha and the gamma. Okay, that means that act both on the diabetes and triglyceridemia. Diabetes triglyceridemia. Okay, so the muscle and adipose tissue leads to the activation of the lipoprotein lipase, increased fatty acid oxidation, increased HDL synthesis, etc. Examples here: fenofibrate, gemfibrozil, bisafibrate. Gemfibrozil is available earlier. Now it is replaced by the fenofibrate, because gemfibrozil you have to take 3 times or 4 times a day, whereas the fenofibrate OD. So convenience space. Side effects: myopathy, hepatotoxicity, rise in serum creatinine levels. See the field trial. However, in the field trial, there was a reduction in the microvascular complications. So there is a big trial on the field. In the same way, rosuvastatin, we have one trial called Rojastat trial. Rosuvastatin. See the saroglitazar. So this is a dual PPR alpha and the gamma agonist. Reduces both the diabetes as well as the hypertriglyceridemia. Dose is 4 milligrams OD. So here the case study. A 51-year-old male, type 2 diabetes for 9 years and is on oral anti-diabetic drugs. Fasting 158, cholesterol 305, triglycerides 132, HDL 30, LDL 249. So what measures would you take to control the lipids? Before the statins, lifestyle changes. First, therapeutic lifestyle changes. So your dietary approach, your exercise, etc. Then coming to the drugs, you have the 5 drugs. One, the statins, fibrates, ezetimibe, PCSK9 inhibitors, bempedoic acid. Okay. So here, what abnormality is the lipid profiles? Cholesterol will be high, LDL will be high, HDL will be low, and triglycerides will be the normal. So the only drugs you can help you is the good answer, statins. So statins will reduce the LDL, statins will reduce the cholesterol, statins may increase the HDL also. Only use the statins. So how much statin you use here? Rosuvastatin, new case. That is the right answer. Because LDL, how much the LDL here? 249. So high intensity statins will reduce the LDL by 50%. So 50% తగ్గినసరి ఇంకెక్కడ వస్తుంది మనకి 125 దగ్గరికి వస్తుంది. So very high intensity statins we have to use. So rosuvastatin at the dose of not even 20. Yes, 40 also you can use it. Even 20 is the right answer. 40 is the best answer. Okay, 10 is the wrong answer. Okay, so this is how you have to see that. Dikshitulu, am I clear? Good. Now this you tell. Female 45 years, type 2 diabetes for 7 years, and is on oral antibiotics. Fasting blood sugar 175, cholesterol 185, triglycerides 510, HDL 30. So what is your working diagnosis here, Dikshitulu? Okay, diabetes and dyslipidemia. So among the dyslipidemia, which one is abnormal? Very good. So which drug you use? Good answer, good. Why don't you use statin? Serum cholesterol less than 200. Okay, so then you need not have it. So even if you want to use a statin, you can use the 10 milligrams of the statin, because it's a diabetic and uncontrolled diabetes. Because statin is a pleiotropic effects are there. So I think the best answer is fibrates plus statin. Fibrates plus statin. Even if you forget the statin, you have to remember the fibrates here, because the cholesterol triglycerides 510. So why should you treat here? Otherwise, the person will land up in the surgical ICU with a complication of pancreatitis. So the treatment of the pancreatitis in the surgical ICU will be costing about 2 lakhs to 3 lakhs. Okay, so that is the main reason. Good. Now this Mrs. 53 years, female, type 2 diabetes for 8 years, and is on oral anti-diabetic drugs. Fasting 163, cholesterol 310, triglycerides 515, HDL 30. Again the working diagnosis, diabetes and dyslipidemia. Okay, in dyslipidemia, abnormalities in LDL and also triglycerides. So what drugs you prescribe? To reduce the cholesterol, statin. To reduce the triglycerides, fibrates. A combination of the statin plus fibrates is here.
Maximum dose of fibrates, how much it is?
Fibrates, it is available in the strengths of 145 milligrams and 160 milligrams. 145 and 160, usually 160 milligrams. Very good drugs. Within 1 month, you will get the normal triglyceride levels. No, combination is available. Whatever the etorva you say, just add F. Rosat means rosuvastatin. Rosat F means rosuvastatin plus fibrates. Etorva F. So etorva is atorvastatin plus F means fibrates. That is your triglycerides. So all the statins, phenofibrate.
Any other? Like atorvastatin, rosuvastatin, nystatin. Fibrates only fibrates there or any other?
Only phenofibrate, because we are using the phenofibrate only because OD dosages. Now you have only 2 fibrates are available. One is a phenofibrate, second one is a gemfibrozil. So gemfibrozil TID dose or 6th hourly dose. So nowadays we are not using the gemfibrozil. So only fibrate available right now is the phenofibrate. So you add the phenofibrate to your atorvastatin or your rosuvastatin. So now the ABCD strategy. What is ABCD strategy here? Advise the patient and his family regarding the prevention. Advise. A stands for advice. B, BP control. C, cholesterol control. Detect early to prevent the. D means detects the early to the prevent complication. Now I say A, A1C control also. A, A1C control and advice. B, blood pressure control. C, cholesterol control. D, detect early, early to prevent the complications, and also diet. E, add E, that is exercise. Okay. Thank you very much for your patient hearing. And if you have any queries, I will be very happy to answer them. Thank you. Thank you.